I'm Scott Spear, and I'm chairman of the Department of Plastic Surgery at Georgetown University Hospital. My primary job is to take care of patients, particularly women with various problems such as breast cancer, women who need some kind of reconstruction, women who have other plastic surgical needs of one sort or another. Perhaps one of the most exciting things is the most recent thing where we now do a lot of breast reconstruction where we don't remove any skin at all. This is called nipple-sparing mastectomy. It's not for every patient, but we do it for a lot of women when it's technically possible and when the state of the disease allows us to do it. We shell out the breast tissue, but we keep all the external appearance of the breast, and we replace the tissue we've removed either with an implant of appropriate size or the patient's own tissues. So to the outside world, it looks like nothing really happened. But inside, the breast has been removed and replaced with something that doesn't get cancer. So this is very exciting, and we do it every week now. And in fact, 5 years ago, we rarely did it, and today we probably do it on perhaps half of the women who have breast cancer that get a mastectomy at Georgetown. My personal trip through dealing with various things as a plastic surgeon has left me with the feeling that it's the treatment of women with breast cancer and their reconstruction that has been one of the most satisfying things for me and keeps me going, frankly. Helping people and seeing a smile on somebody's face who's been reconstructed after having been diagnosed and treated for breast cancer, and seeing that smile because they look in the mirror and think they look beautiful really makes it all worthwhile. In the realm of breast reconstruction, there are a number of different ways we can reconstruct a breast. Sometimes we reconstruct by taking what's left after a lumpectomy, let's say, and reshaping or reconfiguring the breast so that we wind up with a breast that may have a different shape but a normal or attractive shape, rather than one that looks like it's had a piece removed. Sometimes we reconstruct the entire breast. We can reconstruct it with an implant. Sometimes we reconstruct it with an implant plus some of the patient's own tissues, skin and or muscle and fat. And sometimes we reconstruct it with just the patient's tissues alone, often from the abdomen or sometimes from the buttock. Breast reconstruction is an elective thing. In other words, a woman could go forward with a lumpectomy or a mastectomy and choose not to deal with the cosmetic alteration from that. But for many women, that's a significant issue in terms of their self-esteem and appearance. And so for those for whom the appearance of their body is important, we can offer breast reconstruction so that they can continue in life looking normal. Or sometimes, if we're lucky, even better than they started. We pride ourselves at Georgetown for offering lots of different options in breast reconstruction. We believe there are some places that only offer one or two options. In our hands, we offer many, many more than that. So again, just to review, we can reconstruct the breast with the remaining tissue. So sometimes a woman has enough skin and breast tissue that we can make a breast from just what's been left after previous lumpectomies or biopsies. We can reconstruct the breast with devices. One of the exciting things that's happening is we're leaving more and more of the skin, sometimes including the nipple. So we don't need to replace skin, we just need to replace the volume. And we can replace the volume with implants as one of the options, sometimes in stages with a temporary implant we call a tissue expander, followed later by an implant that's picked to most precisely match the patient's goals or the other side. And then we can use the patient's own tissues, and we can get quite creative with that. We can move tissues while they're still attached to the body, or we can even transplant tissues from the patient's body from one site to another, from the abdomen to the breast, from the buttock to the breast, from the thigh to the breast, using microsurgery where we, just like a kidney transplant, we transplant and disconnect and hook vessels, blood vessels back up. Well, here at Georgetown, we were pioneers in what we call immediate breast reconstruction. And immediate breast reconstruction is the opportunity to reconstruct the breast immediately after the previous procedure for the cancer, whether it's a lumpectomy or a mastectomy. So the majority of reconstructions in the United States today are done as immediate reconstructions. So the patient has the first step at least done the same day, the same operating sitting as the mastectomy or lumpectomy. Sometimes we do it as a delayed procedure, and delayed can be 2 or 3 weeks after the cancer operation, 2 or 3 months, or even years afterward. So my advice is the best way to choose a surgeon is, number one, ask other people that you know, either professionally or personally in the medical world, where they would go. Find people who've had the same problem you had and ask them where they've been and how they were treated. And in the scheme of plastic surgery, you might even ask to let you see how their surgery turned out. Then ultimately you have to interview the surgeon and get a sense of how aware they are of your situation, how experienced they are, how tuned in they are to you, and then also ask to see their work, and even ask if you can be in touch with some of their patients. We'd like to think that anybody who's come to see us is probably going to stick with us because we have so much experience and frankly have a lot of patients who can share their experiences with anybody who's looking. The best candidates for reconstructive surgery are probably those people who want it. That's number one. You have to want it. It's not like dropping off your suit and having it cleaned and picking it up the next day. You have to go through the procedures, so you have to be motivated properly. Generally speaking, being reasonably healthy makes you a better candidate. If you have a lot of other illnesses, let's suppose you have bad heart disease and bad kidney disease and diabetes and hypertension, and you're massively overweight, you're probably not a great candidate for reconstructive surgery. There is no absolute cutoff for age for having breast reconstruction. I think the youngest I've done has probably been 15 or 16, but that was a breast reconstruction not for cancer but for trauma or congenital issues. And probably the oldest reconstruction I've done has been in someone probably around 80. So there's no absolute cutoff. The average age when we look at the data is in the mid-40s, probably about 45 or so is the average age of a woman undergoing breast cancer and breast reconstruction treatment, which is not surprising because that's probably about the average age of a woman who's treated for breast cancer. At the moment we have those two choices. You can have an implant, which is a silicone rubber filled with salt water, which is saline, or you can have a similar silicone rubber implant filled with silicone gel, which is like a jelly, okay? At the end of the day, in my opinion, the saltwater one's always going to be the safest one because it's just a balloon full of water, so it's hard to compete with that in terms of safety. But it has some issues in terms of how well it works. So the saltwater one tends to feel firmer, bouncier, look a little bit less real, and feel less real. Sometimes even feels ripply, or like the surface of a balloon that's partly filled. The silicone gel implant is much softer and more authentic, and generally speaking they're very safe as well, but the issue there is that if that implant breaks, then the gel gets out of the balloon and it gets in contact with your tissues. So when patients are trying to decide, it's a little bit of a trade-off between how authentic it looks and feels versus the safety coefficient. They both perform well, they both are safe. For my patients in general, I prefer the silicone implants because they give us more options and more control over how the result turns out. But for many patients, the saline implant is the choice because of the safety issue. So once you've had a mastectomy, you really don't need a mammogram anymore because you don't have a breast there anymore. Sometimes the breast reconstructions we perform are so authentic that the radiologists want to take a mammogram of it because it looks like a breast, but there in fact is no breast tissue. So generally speaking, we do not recommend mammography in women who've had mastectomies and reconstruction on the side of the reconstruction. So if they've had 2 or bilateral mastectomies and reconstructions, then we don't recommend a mammogram at all. So the surveillance or monitoring in those patients is done differently by physical examination, by other kinds of x-rays, by ultrasound, and sometimes by MRI. How long the surgery takes and how long one's in the hospital depends on what procedure we do for the breast reconstruction, but bear in mind that breast reconstruction is a process, it's not an operation, and it typically takes us the better part of a year to finish it. I sometimes liken what we do to like decorating, and so you don't just do it in one moment unless you're on Extreme Makeover, you know, home edition. We usually have to do it one step at a time, so we start out by building the basic breast shape that we want, and then we fine-tune that breast shape, and then in most patients we make a nipple, and then we even color the nipple with tattooing later. So it takes us about a year to finish the typical breast reconstruction. If we do a device reconstruction with a tissue expander or implant, that's usually about a 1 or 2 hour operation for one breast, and most patients go home the next morning after that, even if they have a mastectomy at the same time. If they have that later as a delayed procedure, they can have it as outpatient. So that one of the advantages of a device reconstruction is it's much less surgery, shorter, quicker recovery. If you have a flap reconstruction using your own tissues from the abdomen or buttock or whatever, those are usually 3, 4, 5, 6 hour operations. They usually require a several day hospitalization, and they come with a little bit more risk in terms of the surgery itself, in terms of bleeding and wound problems, because they're bigger operations. When you can go back to work really depends upon what operation you have. So the most common scene is an immediate reconstruction with a tissue expander or implant reconstruction. So in those cases, you'd go home the next day after the surgery, and generally speaking, most patients need about a week or 2 to recover from all of that before we would encourage them to go back to their job. So about 2 weeks, let's say. If you have a delayed reconstruction where it's just putting a device in long after mastectomy, you could probably go back to work sooner, maybe in just a few days or a week. So you're not recovering from the mastectomy at the same time. If you have a flap reconstruction, we generally recommend about 4 to 6 weeks before going back to work. So that's a bigger operation with a longer recovery. The second stages of these procedures, remember, it's a process to reconstruct the breast. The second stages are usually outpatient operations, and women can go back to work after just a couple of days after those procedures. Basically, you're going to not be able to do your usual things for a while, so you want to get your life under control, get it organized, get your head in the space of having a procedure, try to get other things out of your head, and it's a commitment. So for a week or 2 or whatever, depending upon what operation you have, you're going to be pretty much dealing with the surgery and not dealing with your work or your family or your children or your relatives or what have you. So you need a little support at home. If you live alone, you better find some relative or friend to come help you out for a few days after surgery, and if you have family members who live with you, then you may have to hand off some of your responsibilities to them for a while. One of the things I've learned, having been doing this for about 30 years, is nothing is permanent. And although some people maintain themselves very, very well for a long period of time, most of us age. And so the surgery and your body will age over time. So for example, if you have a flap reconstruction where we make a breast out of your own tissues and you gain a lot of weight, well, that breast will get bigger because it thinks it's from your abdomen. So just as your stomach would get bigger, your breast will get bigger. I would say if you're 45 or 50 years old and you have a reconstruction with an implant, the odds are that you probably won't need to replace it, since most of us have a life expectancy of about 80, but some of the patients will.